All right. Well, welcome everyone, to those in the audience here live and to those that are on the internet with us. This is a very special event. It's the very first time that we're doing something like this. We're looking and thinking about human trafficking. We're bringing together people from law enforcement, healthcare, and education to think about this in a very different way, a special event that tries to address a problem that we're going to try to show to you that is very relevant for all of us to know about. Today, we have a group of panelists that, along with a survivor, that we're bringing in to talk to you about the scope of human trafficking and what we can do about it as healthcare professionals. So our panel with me today includes Jose Manzales, who is an officer in the Human Trafficking and Sexual Exploitation Unit and deals with the survivors of human trafficking. We have Françoise Filion, who's an assistant professor in the Ingram School of Nursing, who's focused in community health. Loic Simard-Villeneuve, many of you at the Simulation Center know. Loic is our standardized patient educator and has been thinking about ideas around how we can help in ideas of social justice, such as this. And Nikki Solis, who's our education manager here at the Simulation Center, and she is sort of the person that spearheaded the idea of bringing something like this out there. And I'm going to give all credit to these four people who've designed this. Later in this presentation, you will get to meet, hopefully, if everything works out, a survivor who's gone through this and that can give us their story. We have an issue. The person that we had that was coming in as a survivor has actually not been able to join us today. So Jose has reached out to get somebody else to come in. They should be arriving in the next few minutes as we're working through this, but hopefully we can get to them at the end of this presentation. We apologize if there's any problems and we can't get there. So we're going to get started. What I did want to tell you is a couple of disclaimers. One, we want you all to learn about this. We're doing this in the context of McGill University, which is in Montreal, Canada. The context is different here. The laws may be different. And we want you to understand that this is our context here, and you may not need to think about it within your context. We're all learning about this. There's a lot of learners in the room. Our hope is that you take this home and that you live this and can think about this for recognition, those of you that are healthcare professionals, and get the right people into the right place. We've heard examples of how people that have gone through this training have actually been able to apply this in the week after that they went out in their clinical environment. So I'm going to turn over to Nikki, who's going to start us off with our panel discussion, and then we'll come back over and watch a little video and have some further discussion.
Thank you, Farhan. I wanted to actually start by saying that human trafficking is one of those things that you bring up the term and it evokes an emotional response. But it's also, ironically, the thing that is very misunderstood. I've had the pleasure of actually speaking with Jose over the last few weeks in preparation for this meeting, and we've actually had some conversations about myths and misconceptions of human trafficking. So I wanted to actually start the discussion with you, Jose, to talk a little bit about what human trafficking is, what it isn't, and what are some information, background statistics that our viewers should know about.
Having us. I think it's a very important issue that's taken on a lot of police in the last few years with the usage, mainly of all the social media with internet. It's changed quite drastically the profiles, the situations we're dealing with now, and the quantity as well. So when we're talking about human trafficking, I think what's important to understand is that there's different forms of trafficking. So we're looking at labor, we're looking at people that are promised to be married in another country, we're looking at different situations, but we're also talking about sexual exploitation. It's one of the main forms of trafficking, and if you look statistically, whether it's internationally or locally here, we have a big issue right now with that particular form. So it means somebody housing, transporting somebody in order to take profit off of that person, forcing them into the sex trade and taking all the benefits, the money, and everything that comes with it. So the problem right now is it's actually proposed to the victims or to the people that are caught up in these situations as being a very interesting plan, a promising one. It's something that's very beneficial when it's presented, and a lot of the victims suffer manipulation. Or they can also be trapped because there's always a form of violence that's used to keep them trapped in that situation, whether it be physical, whether it be psychology that they're using against that person to keep them against their will. And if it's not physically towards them, they'll gear it towards the person's loved ones. So these are different strategies that are used. A lot of the people don't even notice or even don't realize they're victims until it gets pretty ugly and pretty dangerous. So when we're talking about human trafficking, it's an issue that strikes anybody, no matter what background they come from. Now our traffickers use the social media, and it's something that has brought us to realize that no matter your level of education, no matter the financial background you come from, anybody can be targeted. And basically they can access people straight in their bedrooms because of mainly the big reason for that being that the usage of the social media. Now a lot of our youth that don't have the life experience will express or expose a lot of information on these platforms, and these people just basically reach out, comment pictures, something very simple, and engage with people with common situations they might have gone through, and they're quite friendly. You know, they can be quite charismatic when they actually lure them into this. So the grooming process that we call to desensitize them to this, or to make this be something normalized, may take many weeks, may take a few days, depending on who they're dealing with. A lot of us personally will, you know, quite randomly connect your status, if you're in a couple or not, post different ideas, pictures that will give a pretty good insight on what we're going through and what our state of mind is. So that makes it quite easy for them to go and target specific people. One of the main myths we also come across a lot, because it's securing to society in general to think that it's always people that come from overseas, it's always far from our personal situations. This is one of the major myths when you look at Canada, especially because Canada being such a vast country, you look at the limitations we're dealing with. You know, we have many provinces, and what we're dealing with right now in our stats is that the vast majority, and I'm very conservative when I say maybe 90% and more of our files are actually people that are Canadians, that are here, local. So they're being taken from different provinces to provinces, that's quite true, but it's not something international all the time as we may think. It's a lot closer to us and to our families. So it's one of the main myths that sometimes when you look at the way we look at this problematic internationally, well, if you go to Europe, the limitations are a lot closer from one country to another. So it makes it a reality over there that's not necessarily something that's applicable here in North America. Another reality that explains that obviously is financially. It's very lucrative, and that's why it's the main type of form that's taking place as much internationally than locally, because it's the one that people can make a lot of money off of. And here in Canada, prostitution is quite cheap compared to our neighbors in the United States. So the laws are different as well. And we also have another reality here. We're considered adults at 18. Rather than our neighbors in the United States, we're talking of 21 years of age. So that also impacts the reason why we are kind of caught up. If you look in locally, if you look in like in an urban center like Montreal, we're looking at about 300 cases and more a year. So it's yearly. The vast majority of our victims don't necessarily want to press charges because they fear the justice system for different reasons. They're being geared that way as well. So they feel like what they're doing is criminal and that they could be charged. They have different fears that are, you know, put in place to make sure that they're kept silent and isolated. And the other also reality we see a lot is because they get pretty known, or, you know, we're starting to have more specialized teams that work this type of problematic specifically, that pushes our traffickers to try to bring the victims outside of our province to keep them isolated. And also, they're worth a lot more, because Quebec, being French-speaking, is considered very exotic. So it's interesting to, so a lot of the girls are brought out west or towards Toronto, that's close to the border. So they're all financial realities that we do come across and that are not, sometimes are misunderstood or not known simply.
Actually, that raises an interesting point. I read, and I think the prevalence on human trafficking, it's very hard to get a true sense of what's really going on because the reporting is not where we need it to be. It's statistically, at this point, we don't really know what we're dealing with. I read in an article that the range people could make up to from 200 to 300,000 per victim in a year. So it is very lucrative. And I believe there's also the United Nations presented some interesting statistics that you brought up. Perhaps you want to shed some light on a global level with the number of victims.
Yeah, we're looking at, when we're talking about sexual exploitation specifically, we're looking about 79% of the numbers of files that are related to the human trafficking internationally are mainly, it's the main statistic if you look worldwide. Here, I mentioned it's about 90%, so it's even higher for us. So these are realities that we do have to take in. And the other thing is it's the crime that right now internationally, and it's also the case locally. And when I say locally, I'm talking for the main urban centers. We work with urban centers throughout Canada. So I'm very comfortable saying it's all of our realities because we work together on a weekly basis. So what we've observed is it's the criminality whose progression is the rate is the most rapid right now. So it's something very important. It's not something that's going to go towards, it's not going to diminish, but we need to find better ways to target this problematic with different ways. So there's repression, there's prevention, there's intervention, there's all sorts of different ways to make sure we're more aware. The awareness also not just with the police forces, it needs to be also applied in different, I'm thinking here today the importance of the medical field as per se, because these are all places where a lot of the patients or the victims may show up and may have an encounter where the trafficker is not around because he doesn't want to be targeted or identified. So it's important that we share that information in a safe way and in a responsible way, so that we're able to better work together afterwards to offer and benefit that patient the best as we can and make that person's reality the safest one we can. So sometimes it's harm reduction as well, and we have to be very patient. These people will sometimes show up many times at the same service point, especially if they'd had a very good trustworthy exchange with the person they met with. So that's what we're trying to create more and more in the near future. That's what we're hoping to be able to do, is to work together and know of each other's realities, because that's how we're able to give a lot more help to those victims.
It's great. Actually, awareness is a big point. We live sometimes thinking that it can't happen to us, our children, our families. Ignorance sometimes is the biggest obstacle. So today, having this awareness and shedding light on it is very important. I think an important thing is also that it requires a vast number of services in the community to help survivors. And I think if you wouldn't mind taking a few minutes to talk to us about the Survivante program at the Service de Police de Montréal.
Yes, actually, I'm pretty proud to be able to talk about this program, because if we go back 10 years ago, my partner Diane Veillette, that is also one of the coordinators, we put it together, this program together 10 years ago, and because there was something missing in the services we were personally offering when we're looking at the law enforcement. We were acting and responding a lot with repression, but sometimes repression it's the best way to protect someone, and when we're able to use the law enforcement to protect somebody. But in the majority of the cases, victims, for many reasons, don't necessarily want to turn towards that, or sometimes not at that first encounter. So for all these parents also of victims that are 18, 19, 20, they're not less of a person, in less of a danger because they're past 18. So we wanted to be able to offer something, some form of support, and enhance also the coordination between the different services, whether it be community organizations, institutional organizations. So we decided to also give a voice to the people who had been in that situation, because we thought they were probably the best to give us a little bit of an input on what are the needs, what was missing, what worked, what didn't. And so they started 10 years ago. We started with the first survivor that will be the survivor you'll be meeting today. She actually was the first to agree and come with us and take part in the trainings we started giving at first with the law enforcement agents, so officers, anybody that, investigators that were dealing with situations like these. And then we started realizing that it was important to speak to the people from the youth centers. It was important to people that worked in the schools, in the CLSCs, in the health system. So we started giving this information session out. Basically, we address what the human trafficking is, what are the different forms, how does it happen, what are victims and traffickers' profiles, how do they collaborate together, how do they function, and how do we intervene when we're in front of somebody that has that particular situation that they have to deal with, and who are the partnerships we actually suggest that would, work the best. So we were able to also share a couple of situations we had gone through and explain what the obstacles were and what the solutions that came out of these situations, and give a voice to these people so they can actually explain the before, while, and after. How were you lured in there? What was your line of thought? What were your actual impressions on the services and what was out there? Once you were caught up in there, how did you feel? What were your options? Why didn't you go take the phone and call for some help? Why didn't you go knocking on the medical person you were in front when you went to get medication? Why didn't you ask help at that moment? What were the good and bad encounters you had, no matter what the line of, the services you went for? And now that you're out, what are your impressions on all of those elements? So that helps us really reconstruct and go back on certain interventions we might have done and said, how could we make them better and more efficient? And it gives a little human aspect to it that's always missing in all of our training programs. And it it worked so well because the people responded quite positively to this. After only 3 years of giving these sessions, the number of files we were treating went from 10 to, we quadrupled, and now we're up to 300 a year. That means there's better detection being done. People are more confident. They target and maybe realize or detect things much easier because they're more aware of how it works and how it functions and what state of mind that person is in. And it also helps our health providers, but also our law enforcers or any professionals that are dealing with families or with people that are caught up in this, also protect themselves and not be carrying on those shoulders the mass majority of the impacts that this type of crime may have. So they take their part and they're able to rely on other partnerships to be able to make this something much healthier way to intervene and protect ourselves as professionals as well. Now we have 12 survivors. We also have one man that, because that's another myth, it doesn't just target women and young girls. In the statistics, yes, in the police statistics, it barely even shows, just like women that come from the Aboriginal background. So these stats it doesn't show in the stats, but they're very present. 50% of the clientele and the victims in the sex trade are considered being women that are from the Aboriginal women. So it's something we need to better target. So we started working in the communities and created another part to our program where we have an Aboriginal part to it. And we're also working on the male prostitution that barely shows either. But working on the field, we meet people and realize that it is an issue and that we need to better understand it just like we did 10 years ago. So it's something that has been quite beneficial. The survivors can also meet with certain victims in a very structured intervention as well. So that's also available, and as well for parents that may want to meet a survivor and ask certain questions. There's something out there, there's this type of service that we put together to answer that.
Thank you so much, Jose. It's wonderful to hear the progress that you've made and how you're helping us identify the scope of the problem. Françoise, I was going to turn over to you. And first off, in my role as the Director of Education here, I wanted to congratulate you on thinking about something that's a social justice issue and bringing that to the forefront in simulation. And I don't think we do that often enough. So first off, congratulations for doing that. I wanted to ask you, as a nurse and an educator, what prompted you to bring in human trafficking into your curriculum. What was the trigger, and how did you bring it in?
Yeah, so I always think it was quite important to really like cover or include human trafficking into our curriculum for healthcare professionals. Because like, you know, like Jose mentioned it a bit, it's like sometimes you will have, like for example, a nurse will have a very short period of time, could be just 10 minutes, with someone that can be a possible, you know, human trafficking victims. And what happens if they are not trained, it'll be really difficult for them to be able to intervene and help. So last year, when I started to, the first time that I used a human trafficking simulation, I really wanted the students to have some red flags. I wanted the students to have to be some kind of an awareness, like they sensed something was going on, but they were not sure that they were really meeting human trafficking victims. So we only debriefed this after. So we did this in debriefing. So, and also, I really didn't want the students to confuse conjugal violence with sex trafficking, because it's not the same thing. It's quite different. There's power, of course, involved, but it's not the same. So I really, you know, didn't want them to confuse that. And again, without any formal teaching, it's really hard for a healthcare professional to really, I would say, find signs and symptoms and be able to intervene and help the potential victim.
So help me. I'm a pediatrician. This could happen anytime in the patient that I see. What are the red flags I should be looking for, that our colleagues should be looking for when somebody comes in?
Yeah, so you've got some on the slides now there, so you can see the red flags. So someone, let's say, that is an individual that does talk for someone else, like the person doesn't talk. Also, the person can be very nervous, anxious, and avoiding eye contact. So that's something that we can see. And also doesn't have her own identification document. It comes from someone else. The person, you know, she will not have her document. And sometimes also you can see some tattoos, especially us as nurses and the healthcare professional, we can see some tattoos, and some tattoos that will be sometimes on the genital, you know, tattoos that will be maybe a sign, a dollar sign, or maybe like you have other than, it could be also a man's name, it can be daddy, it could be some kind of something that you can see, some tattoo. And also, if you're looking at some kind of like more physical signs, you will have like unexplained injuries. You could have burns, and especially cigarette burns. And it could be on the hand, on the top of the hand, and it also can be, you know, on the breast or genital. This is something that you can see. You also have like, you know, bruises. You'll have bruises. And sometimes head injury, because sometimes the head is targeted. This is something that can be targeted. And it will also cover, if you're looking at other slides, cardiovascular, GI condition, then you'll see weight loss, malnutrition, and also a big part is also the mental health problems, where you will see depression, anxiety, you can also see suicide ideation, and dissociation disorders. That's really something that is prevalent, and it's something really important to, you know, to talk about, because this is like when the person really see themselves disconnected with their body, and this happened because this is a coping mechanism. So this is seen, and then when we're talking about, you know, survivor, they're also going to tell you, you know, it's not me. It's almost like it's like it's happening, but it doesn't really happen to me, and it is like a coping mechanism, of course.
Thank you very much. Are there any barriers that healthcare providers face in trying to identify this? Are there things that stop us from being able to identify this?
I would say lack of knowledge. Like, that's a big thing, lack of knowledge. And also, I find that there's no formal clinical protocol. We don't have that in the hospital. We don't have that that's in ER. We don't have that in clinics. This is something that doesn't happen. And also our regulatory body, like I'm talking about nursing, we're talking about the OEQ, they don't have that either. We don't have this formal protocol. And I would say also a lack of our deontology codes. Always our deontology code can be applied to this you know, to this situation. Also, what I find, it's also what I found with my students, it's difficult to have, you know, to ask pertinent question. What is the pertinent question? What can they say? Is this okay, not okay? So that's a bit difficult too. And also confusion between confidentiality and getting consent. This is also something that is blurry. So this is something that they have to learn. And again, because healthcare professionals often they're not trained with human trafficking victims, it's really difficult to provide them assistance, help them.
Thank you. Nikki, I think you were going to turn over to ask Loic.
So Loic, as a standardized patient educator at our center, you basically develop and run programs daily. And we wanted to turn to you and ask you, what can simulation-based education do for social justice issues?
Okay, so, well, first let me explain what is a standardized patient. We have a slide here that has the basic definition. Here at McGill, most of our standardized patients have a very strong background in the dramatic arts. And also, most of the scenarios that we use during our simulations are based on a real patient. So those two factors coupled together make for, most of the time, that's what we aim for, very realistic simulations. And what's great about standardized patients is that the students can learn and practice communication skills in a safe environment where they are allowed to make mistakes because it will not have a direct impact on a real patient. So that's what the standardized patients do here. And so what's interesting is that, unfortunately, concerning the social justice issues, the statistics in the US show that actually there has been a decline of victim care education. So from 2010 to 2014, there was a decline of 7%. And another stat is that only 38% of graduating physicians experienced victim care education throughout their curriculum. But on the other side, what's interesting and what we can do about this is that we can incorporate social justice issues in existing scenarios or existing programs without having to create a whole new program or change the curriculum. And that's actually exactly what Françoise did last year with a program she had been running here yearly. She decided to change one of the scenarios and make it about human trafficking. So like you were talking about, congrats to that. It's our first step here at the Sim Center. And so the goal of these is to, social justice scenarios is to really better equip, like we've been talking about, these students so that when they do encounter in their clinical setting victims of human trafficking, first they'll know how to detect that they are a victim, and they'll have definitely more know-how on how to deal and help them. So this brings me to Carrie Bonnert, that is the director of the Standardized Patient Program of the University of Louisville School of Medicine. She created a webinar this past November on human trafficking for the Association of Standardized Patient Educators. And I just wanted to thank her because she was a great inspiration for us. She's actually one of the reasons why we're holding this webinar today. And I wanted to mention that in her webinar, she said that at the University of Louisville, they had a simulation on human trafficking on a Monday. And one student reported that 2 days later, when he or she, I don't know the gender of the student, was back in the clinical setting, actually was able to detect a victim of human trafficking and was able to help them, whereas everybody else at that hospital failed to detect that that person was a victim. So that really goes to show that small measures can have a real and big impact. So short of being able to have you experience right now a simulation like we do at the center during this webinar, we did create a short video that illustrates a rather positive encounter of a nurse and a victim. So we hope you enjoy it.
Hi. We need to see someone. She's in a lot of pain.
Sure, no problem. Just give me a sec. What's your name? Hello, Star.
Her name's Natalie Braun, but everyone calls her Ella. So it started a couple of weeks ago, and we thought it was going to go away, but it's actually getting worse. She's in a lot of pain.
Okay. Have you been here before, Ella?
No, we haven't been here before.
Okay, so I'm just gonna make a new file for you, Ella. Do you have your Medicare card, please?
Yeah, here you go.
Thank you. Okay, so what's the problem?
It's her tummy, as you can see. I used to work in a hospital when I was young, and I could tell that this level of pain, it's just not normal.
Well, Ella can tell the nurse all of her symptoms.
I think it's just her abdomen. Right, Ella?
It's the back too.
The back, too.
Janelle, is there anyone else to see now?
Yes, actually, just give me a moment. Ella is gonna be your next patient.
Thank you so much. You are such a sweetheart for squeezing us in. We really appreciate it.
Yeah, no worries. It's pretty quiet today, so it shouldn't be a problem. Here is her file. She's a new patient. So, sir, you can actually have a seat in the waiting room over here.
Oh, no, there's no worries. I don't mind. Like I said, I used to work in a hospital, so I'm used to these kind of surroundings. And I think Ella might be a little bit frightened by it. You know, this whole setup that you have here. I'm just kidding.
Oh, it's okay. I'm sure I'll be fine alone with Ella. So if you don't mind just waiting in our coffee room, and we'll be sure to come get you if we have any questions.
Yeah, I think Ella would prefer that I stay with her. Okay. No problem. Right here if you have any questions or anything. Right here.
Okay, come on in, dear.
So you can have a seat in the waiting room just behind you, sir.
Oh, no, there's no problem. I don't mind waiting right here.
That's so sweet, but she's really in good hands now. There's no worries. Please, sir.
So good morning. So your first name is Ella, right? Can I call you Ella?
Sure.
All right. So Ella, it seems like you're in a lot of pain. If it's okay with you, I'm going to ask you some questions about your pain and just maybe some other questions to help me get to know you a little better so I can know how to help best. So we'll do this first, and then I'll examine you after, okay? Is that all right with you?
Sure.
Okay. So when did the pain first start?
About 2 weeks ago, but it's gotten much worse in the last few days. I can't work.
Oh, what do you do? Where do you work?
I accompany men who need companionship.
Can you tell me a little bit more about what that means?
It's like escort work. Raymond is really great. He brings me to my dates.
Okay, well, coming back to your pain, what type of pain is it?
It's really annoying.
What I mean to say is, it a stabbing pain? Is it a dull pain? Does it come and go, or is it always there?
It can be really bad at times, and then it gets better. It comes and goes.
Okay, now is it bad? Okay, I can tell that it is quite painful. I'm actually going to examine you right now, if it's okay with you, all right? So can you please come to the examining table?
Okay.
So we checked your vital signs, and you have a little bit of a fever, about 38.5, and that's borderline. So right now I'm going to actually check your abdomen. Do you mind undoing your pants for me? I noticed that you're on your phone a lot. Are you expecting a phone call or a message?
I'm checking for messages from my boyfriend. He likes me to verify them and answer him. He doesn't like to wait very long. He's not very patient.
Do you think you could be pregnant?
I don't think I am. I had an abortion 3 weeks ago, and I always use protection with all my dates.
And your abortion, was it done at a hospital or a clinic?
It was like at a private place, like a home clinic.
Okay. Can you please sit up? Ella, I need to ask you a very serious question. I want you to know that you're safe with me, okay? I'm not going to tell Raymond. I won't reach out to the authorities unless you want me to. Do you feel safe with Raymond? Does he, like, are you free to come and go as you please?
He takes care of everything, even the money I make.
I noticed some old bruises as well as some new ones on your face and neck. Were they caused by Raymond?
It's not very patient.
All right, well, Ella, I'm gonna need to run some tests for your pain, okay? Because it could be an infection.
Ella, everything okay? I'm just checking on her.
Let's just do it quickly because I don't want to anger him.
Okay, we're gonna do a blood test and a urine test as well as a pregnancy test just to make sure that there's nothing left in your abdomen after the abortion. And Dr. Pearson is definitely gonna want to see you before you leave, okay? Ella, I want you to know though that we can help you, okay? We can offer you birth control that you don't need to take every day, like an injection, and it can last 3 months. Also, if you want to get tested for sexually transmitted infections, then I can give you the name and location of a community organization that does checkups for free. And if you want to keep talking with me now, if you want my help right now, and just say so, okay? And I will do it right after your tests. But only if you want me to.
Okay.
So you can see the power of that case. Everybody in that scenario was actually a standardized patient. So the nurse was a standardized patient playing that role. But you can imagine yourself as a healthcare provider in there and living that and having the opportunity to practice and how that practice might actually help you to get better. So I'm going to turn over to Françoise, who's going to help me understand. Françoise, in looking at that scenario, what did she do that worked, that was helpful, that I should take away and do when I'm in practice? And are there any tips that I can learn from that perhaps she didn't do quite as well that I can take home and say, I might do that a little bit better?
Yeah. So I think the nurse Florence was really able to be alone with Ella. I think this was very important, and she really was able to also speak to her alone. And what also she did, Florence really took the time to make this relationship, this therapeutic relationship with Ella. And what was nice too, she already offered really essential information about birth control and also about where you get free STI testing into the community. So that was quite interesting. And she also ensured consent to Ella, so that was important. And she engaged another healthcare professional. In that case, will be the physician that will see Ella. So that was also important. What can be improved? Probably what can be improved, I would say, maybe provide some kind of a timeline. I mean, this is something that she didn't really say. It's how long the test will take, and then you can take this door, you're not going to have to go back into the waiting room. You can take this door, and then right away after, then you can see Dr. Pearson is going to wait for you. This could have been, said by Florence. And also how Ella and Florence can be safe from Raymond, because Raymond was really knocking on the door, so how can both of them be safe? Also, making sure that would be really great after this happened, the healthcare professional that were really linked to this case, how they can get together and debrief and say, can we write some kind of a protocol? Or maybe if there's a protocol already written, can we just update it and really work together? And I would say, also again, coming back to our deontology code, how is this, how we can use it as a guide in this situation?
That's great. Thank you very much. Jose, Raymond in that situation was quite intimidating. As a healthcare professional, how do I engage law enforcement, do it safely for the team, as well as the victim? Any tips for us?
Yes, I think the main idea in this is always keep in mind that the victim or the patient has to be at the center of it all. And they've been deprived from all of their decision-making. A lot of them, depending on the time they've been under that individual's control, may have no decisions to be made. Everything's done for them. They are afraid of anything external to their little, intimate bubble. And to them, when you engage with the law enforcement, it can be quite invasive and scary for them. So it's important for them to realize that law enforcement, that option is set out just like any other options. And the main thing is to let them know that even if they do engage into speaking with an investigator, that it doesn't mean she has to press charges. And when I say this, it's very important because a lot of them feel like if they speak to the law enforcement that they, after that, have to go to court and they picture themselves in front of the judge. It's not the case. It's not how it works. We try to benefit and identify that person's needs, and we will target the best option for that person to keep them in a safe place, but also respect what they're willing to do and the state of mind they're in and what process they are in when we meet them. So that's why there's a survivor program with our unit that's specially designed to work with these type of situations. So we have a team here that works not only locally but also provincially. And we also have an option if they don't want to turn towards the legal system, they can actually turn to the survivor program where we can also offer different other types of help. We work with, here we have Sphere, we also have KETSI that are community and institutional organizations that come together and offer different services and different options to anybody that might be trapped into a situation like this one. And it's all very confidential, and we'll try to make it happen and try and respect what the victim's ready to do and encounter. And there's the same thing in other provinces, like there's ACT in Edmonton, there's Streetlights in Toronto, there's different organizations that work with law enforcement to make sure we do that. Now, with this being said, if it's not an option right now as you speak to her, there are other organizations, other services we can turn to. So sometimes it's just a matter of giving them a phone number they can remember or a location they can remember to go to when they are ready or if they do feel safer at another period. And also remember that usually if they encounter services with the medical field or the medical services, just like us, for the law enforcement, it's usually something that follows a crisis. Unwanted pregnancy, realizing you have a sexually transmitted disease that prevents you from working, so the trafficker will accept that you will be able to get some help for that typical time frame. Or if they've been experiencing extreme violence and they're just simply afraid to die, or they're afraid that that person will be putting in action these threats they've been portraying. So when you follow a crisis period, usually that's where the victims tend to take the help a lot more than if they're at another place in the cycle, in that violence cycle. So these are just examples, so it can be just presented in that way and let that person take their own decisions to empower them and not try to take over. So that's probably the best thing. And last little detail: if he's in the hospital or in the clinic, just like in that particular situation, always remember that if you do call and deal with these teams, we will not show up necessarily with the whole. We have to protect the other clients that are in there, and we don't know who that individual is, if they're armed, if there's any potential dangers. So we're better placed to evaluate how we could coordinate with the facility to make an intervention if the victim does want the help. So this can all be worked together.
Okay. So if I sum it up in my simple brain, it might be a pivot point when they come in.
Sure.
It's about their safety and to frame it in their safety, and it's not about prosecution.
Exactly.
And then it's also about the safety of everybody else, so to provide as much information as we can to you so we can develop a plan and then give that person some options for the future state if they're not ready now, but try to make sure that they feel that you're ready to listen or that healthcare is ready to listen.
Exactly.
Okay, thank you. Thank you.
Well, one, I actually, for those who are not here, we wanted to actually thank Zoe for coming in. I know that there was some changes along the way, and we can't thank you enough. In the world of simulation, we often say that the best education happens when you have the logical mind and the emotional heart that come together to share the person's story, the whole story. And that's what we strive to do every day. And without you today, I don't think we would have been able to accomplish that. So we're very happy that we had you attend today. So if you don't mind, we can take a step back and look at how your journey started.
I'm sorry, first of all, for my English. It's not my first language. But my journey started when we moved to Montreal, because I was living in the suburb for a long time. And when we moved in Montreal, I was kind of lost. I was 14 and a half years old, and I was really lost, getting into a big school. And then at some point, I was walking on the street with one of my friends, and then I meet the guy who ended up being my pimp in the future. Just to say, it took a while. I mean, I speak to him the first time. The worst mistake I did is let him bring me back home. So he bring us back to my place, so he knew where I was leaving. So since that day, he was in front of my house every day. If it was not him, it was a sibling, a friend. It was always there. And it lasts at least, and I'm not exaggerate, 6 months before I even speak to him another time. And then I thought, you know, I was 15 and a half, let's say, and then I started talk to him on the phone a little bit. And for sure, in my story, my mother had a big alcohol problem. So I was not having the boundaries a teenager should have. So I was going out with my friend and drinking beers in the park and blah, blah, blah. And then after, like, let's say 3 more months of speaking with him on the phone, I start seeing him once in a while. After 2-3 months of that, he present me a girl, and then that girl tell me she was doing a job that she really liked, and it was good money, and then I could have spoiled my brother and sister, and I could go away from my alcoholic mother, blah, blah, blah. And then I was tired of school. I was not really doing good. I was doing okay, but it was not, I didn't like it. So I said, okay, let's try, and he was so happy for me to try. And then I think that's when I start to kind of fall in love with him. So I kind of do it to make him happy too, in a way. At that time, I didn't see it that way. I see it was my choice. But now I totally know then, it was a setup to make me think that. So I did my first day of escort in November of my 16 years old. My birthday was August, so it was pretty close of my 16 years old birthday. And then after a couple of months, he made me my fake ID, and then I started in the club, plus. So I did that for a couple of months. And then I go back escort, and then I get beat up by a customer really bad, and I tell him I'm never going to do that again. So he put me back into the club. And I remember at my 18 years old, I said everybody, I'm 18 years old, and everybody was like, are you joking, So I was doing it for already a big time. So that's pretty much a journey, the beginning and the middle of it.
I just want to mention that those who are viewing remotely, Zoe is actually protected through anonymity, so we won't be showing her. So my apologies, I didn't mention that. I can't, this journey, it's exactly what Jose explained. It was a long grooming period, and there was the Romeo role. So what made you decide that enough was enough and that this is not going to be my life anymore?
Actually, in my case, I didn't have the choice. Actually, the police saved my life. It's funny I'm here today because I remember maybe a year before I stopped doing this, I started to realize what anxiety was. I always did anxiety, but at not a big amount. Like I was always controlling myself as much as I could and everything. And at some point I couldn't. My body kind of turns off and my anxiety took over. I was not sleeping. I was not eating. Everything I was eating, I was throwing up. And then at some point I wake up in the morning and my pimp was there, and I said to him, if you don't send me to the hospital, I'm gonna die. I'm not gonna be able to work. So I used that as he has to send me if he wants to have money, you know? So he threw $200 at me because I didn't have any medical card. And then I end up to the clinic where I knew, the only clinic I knew because I was going there with my mother. And then I said to the girl at the clinic, and I was crying, like, I could not control myself. I was just crying. And I said to the girl, I think I have AIDS. I remember like if it's yesterday, I said, I have AIDS, I need help. And you know, today to be here, it's really, really emotional for me. Because if the girl who saw me at that time would have just that little, you know, she would never let me go. But because she didn't have that, she gave me a paper for me to go do blood tests, which I never knew where I have to go. I didn't have a medical card. Just to be there was a big thing for me. And then after that, I remember I had to, they give me like pills to calm down pretty much, which was a mistake because after I get addict to Gravol. That was the only feeling. It was bringing back that pill. So I was taking 30 Gravol a day. And I think that's when I realized I need to stop. And, you know, thank God, he got arrested 3 months after. So because he got arrested, I was able to get the help.
So we thank you for sharing your story and so being so courageous. I can't imagine how challenging and difficult that was. Can you help us learn, as healthcare providers, what are your tips for us to do our jobs better so that we can help?
Well, you know, when I see that video, it's just that video is, you got every sign in one victim, you know. I don't think it's never gonna happen. I don't think it's really rare. I think the pimp's gonna follow the victim, from my opinion, because the pimp don't want to be seen. He doesn't want to be seen with you. You're not supposed, you know, as much as he is concerned, you are the reason why he's gonna go to jail if anything happened. So it's better if he never gets seen with you in a public, especially in a hospital or in a clinic. But, you know, the pain and the way she reacts, it's totally it, you know. You know something is wrong. You can see it right away. And I can promise that then if a victim like me, like all my survivor friend, you're gonna know. You're gonna know. Now then you've been here today, and now then you see me, you see Jose, you see all those beautiful people who, you know, you're gonna know. Go with your guts. If you you work for, I don't know how to say it in English, but if you work for the medical system, it's because you have the heart in the right place, and go with your feeling as much as you can, because I think that's the best thing I can tell you, because every victim and every situation is going to be different. And I can tell you so many things to do, but along the way, you're going to know what to do when you're in the moment. And then trust yourself. I believe in you guys.
Thank you so much. I wanted to give a moment, if people have questions for any of the panelists or for Zoe, we have a couple of minutes where we can take a few questions from the audience, if there are any.
Perhaps I can interject. There's no questions. So I wanted to know, you went from victim to survivor. Many services, I'm sure that you needed to help in the rehabilitation process. Can you share with the medical community what kinds of services were there to support you so that you can have the courage today to step in front of us and share?
Well, I'm the first survivor, so obviously it was not survivor program. Actually, the only program who helped me, because I was like me get arrested, so right away it was going to the justice, so I didn't have time to see or really, but Levac's the one who helped me the most. The Cavac and Levac are the one who helped me the most. The Cavac, she was an amazing girl who helped me fill up the paper for my first therapy. So Levac paid my first therapy. And then after that, Levac paid my, they make me move. They pay my moving because I was living one street away from his mother, from my pimp's mother. So that's the main resources I use. Like the police was my main resource. I mean, I was calling, is one of the investigator who always been around me till today. So I was calling him, and he was doing the call for me to help me out. Then after like a year and a half, 2 years of this therapy and then getting out slowly, I had to go do a testimony because I get a subpoena to go to court. Thank God I did it. It took me a long time, but I did it. So you get 6 years of jail. So I think after the police, Levac, and the Cavac, I was my main resources because I go to court. He got 6 years, so it was 6 years of me being able to turn around, not looking up my shoulder if he was there or looking for me. But me, that was the main, Levac, Cavac, and the police.
So community resources were available to you. With
Yeah.
Cavac, perhaps, José, you can
Yeah.
speak to Cavac. I'm not, it's for victims.
It is the center to assist victims that want to press charges or go to court, or those who don't want to press charges, simply being a victim of a criminal action. So basically, they are a resource that can accompany and refer to other resources. But as Zoe mentioned, there's also therapy that was involved in her case. That's something that comes in very handy. We work with different resources like Marie Vincent that offer therapy to the family or to the victims, whether they go to court or not. As I mentioned, it's very important because on our point of view, in the 300 files, to give you an example, there's at least about 100 of them that we actually treat amongst the two coordinators of the program. That means that a lot of the files don't end up going to court. When they do get to court, we have a good success rate. Like in Zoe's case, when they do decide to go there and that they're strong enough and structured and supported enough, we're able to do very good things. And right now we have a 90% plus success rate. So that's very interesting. But for all those who can't, I think that the medical field, all the medical assistance, the resources to support these people is essential. Even when they do press charges, when somebody's supported, that helps out a lot to obtain successful stories in the end, because just like Zoe, maybe you'd like to share when you exit, there are also situations that you have to deal with in your relationships. And sometimes the post-trauma may come and maybe different people react in different ways in different moments, but it's very different from one person to another. We have victims that had suffered post-trauma many years after the incident. So it's something that needs to be taken care of and really carefully addressed when this happens.
Well, like I said, my first therapy was the Cavac, and then after, they make me move. So when I move, I think, nothing happened for nothing in life. Now that I'm thinking of my life, I would never go back because they make me move, and then I did another therapy on my own. I finally find a job slowly, and I think without a therapy, I would never really, I don't think I would made it. Even now, sometimes I'm going back, not about this anymore, because I think I think it's been 3 years, then I think I'm totally recovered from my past. I'm gonna have always thought of it, but the the person, the detective, how do you say?
Investigator.
The investigator who take care of my case, he's gonna retire this year, and then I think I'm gonna probably follow him soon as a survivor, because it bring me back always into my past, and it, you know, when I think about that, it make me emotional. But yeah, like after my second therapy, I finally met my another man. And I was pretty scared because I didn't really trust men anymore. And after even after a year of relationship, every time we make love or we had sex, I was crying every time. And he was really, feeling bad. Until those days, he never really do the first step after 12 years of relationship. He's not even doing the first step. Not because he just, I think it's respect. I think he don't want to make me feel or put me into a place I'm feeling trapped, or I don't know. Well, now we have 3 kids and I'm married and everything is okay. But I mean, I'm always probably going to have minor little detail of my life. Then when I'm thinking or when I'm going to see my psychologist, I'm like, oh yeah, this is it. I'm making the. But I think you can recover from it. I think you can have a normal life after. And thank God I have 2 daughters, and I think I'm going to be equipped to face it if it would happen to me. I would be equipped to face it, That's.
So, Nikki, I don't know if you had any closing words, but I wanted to thank all of you for attending here. Everybody at the Steinberg Center that's here live to listen to this conversation, our colleagues that are online and listening in remote places. I really wanted to take a moment and thank our panelists, because I think they've done a wonderful job of highlighting how important this is for us to think about as healthcare professionals. So thank you, Jose, Francoise, Loic, Nikki, and really, Zoe, thank you. Your story is powerful, and that really helps us to understand. So thank you for the courage to come and talk to us. Nikki, I don't know if you wanted to put up the fundraising slide and just let people know if they...
Today, we realized that we gave a very short overview on a topic that merits a lot more conversation. We think today that 1 hour probably opened your eyes to things, but we can't, as an institution, an academic institution, but also in our hospitals, make a real difference if we don't offer more training. And not a 1 hour webinar, but a real course that deals with role-playing exercises. So for this reason, we've created a Seeds for Change page on our McGill, which is available on the bottom of the YouTube link. We're trying to raise funds for creating a toolkit that won't only be used at the Steinberg Center, could be used in hospitals, it can be used in other institutions. So it will be portable and it will have a very wide reach, so that we can continue this conversation in the forum that it merits over a period of time, with exercises that people can really rehearse and make powerful changes in their point of care. So for this, I want to thank everybody. Thank you, everybody here. Thank you again, Zoe. You really touched us, and I think just the perspective you provided will really change the way people in the room and hopefully people abroad will look at patients in the future. Thanks again for our panelists. Thank you.